And now, without break, we are continuing in our next session about psychosocial interventions, which I'm going to chair together with Dr. Gianni Franco. He will join me soon, I suppose. Let me first introduce you our first speaker, who is Professor Falko SNIEHOTTA, and he will speak indeed about bridging the evidence action gap in non-pharmacological interventions. And let me introduce him briefly. Professor Dr. Falko SNIEHOTTA has been the head of the Department of Public Health, Social and Preventive Medicine at the Center for Preventive Medicine and Digital Health at the Mannheim Medical Faculty of Heidelberg University since January 2021. Previously, he was a professor of behavioral medicine and health psychology at the University of Newcastle and the University of Twente. Falko is the past president of the European Health Psychology Society, associate editor of the Health Psychology Review, and honorary member of the Academy of Social Science, the American Psychological Association Division 38, and the European Health Psychology Society. His research aims to develop and test interventions to change health and healthcare related behavior, and he is passionate about translational research in public health and evidence-based preventive medicine. And I'm really glad, Falko, that you accepted our invitation. Please come to the stage. Falko is doing a tremendous work, and he has done in UK bridging behavioral science and public health. And again, I'm really curious to hear how you see the role of non-pharmacological interventions in all this. The floor is yours.
Thank you, Iveta, and thank you very much for inviting me to this beautiful and important event and for allowing me to speak here. I have to say the opening ceremony was inspiring to me, because I feel that this society has not only captured a really important issue and has conceptually made progress in addressing its issues, but we've also seen how well it is already connected to actors from different sectors like policy, agencies, non-governmental organizations, and I think that's certainly really important. Yes, so my role is well described in these two jobs that I have. I am doing public health, so we are trying to develop interventions to improve the health of the people. We are trying to implement them into practice, and through my role in the UK, which I still hold, by the way, we work a lot with ministers and with officials to try to implement evidence-based action into policy. And I think this evidence-based is what keeps me awake at night, boring as this might sound. So this approach here is something I have to admit that I have never really considered myself to be a non-pharmacological intervention person, but when I got invited to speak here, I realized that exactly is what I've been doing. So thank you very much for giving me a new identity here. When we look into interventions, they usually consist of these really important elements that each are really quite important for the evidence that we seek to translate. So we have an idea about the causal assumptions. Some of us call this theory, but for years most interventions haven't had much of a theory, but they were based on what people thought might be a solution for the problem they were facing. We have some ideas about how they get implemented, and in non-pharmacological interventions that can be quite a challenge, which I would like to illustrate on two examples in my presentation, and to see to what degree can we bring the evidence, as we have perhaps developed this initially in randomized trials, into practice, and the challenges that are appropriate to address. We have usually a clear idea about the mechanisms of action and the level of flexibility it allows us to achieve that and to achieve our outcomes. I think what has been also mentioned in the opening ceremony is the importance of the context. Each country, just in Europe, has a different health system. We are dealing with a context that excludes many people from everyday health care. We are dealing with disruptions, crises, disasters that are now very foreseeable, and we have to future-proof our interventions and our health systems towards those challenges and changes. So this is not the slide you're expecting at an event for intervention on non-pharmacological interventions, but it sometimes helps to look across the border what the rest of the world is doing. And I think there are a few things we can acknowledge here to be relevant for our discussion. The first is the clarity of the statement of active principles and ingredients, which in pharmacology is often very simple and in other areas is often hugely complicated and requires a lot of focus. We appreciate the commercial element in it, which means scalability is usually thought in from the beginning. We appreciate the unequal amount of evidence related funding for research. So if we had the amount of research funding in non-pharmacological interventions that the pharmacology research had, we could make much more progress. And of course, we have a very clear idea what the key elements are that we need to communicate to decision makers as well as to patients for the interventions. So that's the last time I will mention a pharmacological intervention, and I apologize for that, but I thought it is useful to do this. So when we look into interventions, some years ago, we didn't even have clear ideas how to communicate what is an intervention. We would see big trials who would describe their interventions in 3-4 lines in a paragraph under the methodology section. And at the end of the day, nobody had any idea what the intervention consisted of, what the mechanisms were, and how to implement it. And that is one area where we all have made massive progress over the last 10-15 years with inventions like the TIDIA checklist, like various taxonomies to describe intervention content, intervention delivery, and other aspects that are important. In practice, when we do research, we always compare new interventions against standard care. And whilst this is the easy second slide to the thought, it's important that most health systems address most problems in some way before we have considered interventions. And much of what we are doing in terms of research is we are comparing the value of innovation compared to previous delivery, and that often has different comparators. So interventions are inherently very complex, and this complexity makes the evidence hard to acknowledge and makes hard to take good decisions. So I would like to discuss this based on 2 examples, and I would like to look into these examples not only with regard to the efficacy, but also, as a public health professor, you will forgive me that, with the consideration of reach, because many good interventions are only reaching a selected number of people who would benefit from it, and the reach is a very important part of interventions. The adoption, the way we can get interventions into systems, the implementation, the degree to which the intervention is delivered as it has been researched, so to what degree we manage to capture the active mechanisms, and of course we are looking into sustainability and long-term solutions for health and healthcare. For local decision makers and regional decision makers and even national decision makers, implementing evidence is rarely easy. Yeah? We are talking about a complex set of information, some of which is available at different levels of certainty, which is about rigor and is about the kind of things you learn at medical school, but it's also about very different things, about transportability. To what degree is an intervention that has been evaluated in France, in Ghana, and in Australia relevant for Slovakia? What are the relevant factors we need to understand to guide the implementation process? And how do we understand how to choose between different interventions with different levels of efficacy and reach? And I think in these discussions, we often find that decision makers need more structure, need more guidance, and need better dissemination from evidence producers. We recently gave some thought to the role of systems in understanding individual information. So when we try to implement interventions of which we know that they are effective in trials, we often find that there's absolutely no effect when they're implemented in real-life systems. And there are usually one of 2 explanations for that. One is that the fidelity is low. That means we didn't manage to bring the critical dose of the intervention across to the people. But the other one often is that we have structural constraints that need to be addressed. So in that vein, for example, in our work on diabetes prevention, we have developed entirely new interventions for people from a Pakistani background, for women from a Pakistani background, for example, because their social and cultural embeddings didn't allow them to benefit from existing interventions. If we look into changes into our environment, climate change, changes in healthcare systems, we might find that external constraints make it hard to implement an intervention faithfully. And again, we're looking into a level of complexity that makes it very hard to advise on implementation. So this is a paper that you might have come across, Morris and colleagues wrote in 2011, and that's actually a funny title for a paper. The answer is 17 years. What is the question? And the question here is, how long does it take for a new health technology, once discovered, to be implemented in standard care? It is slightly inaccurate, but it is a nice way of describing the following study, which is the way to Healthier You, the NHS Diabetes Prevention Program in the United Kingdom. So the study of my life, perhaps, is this study of the American Diabetes Prevention Program, published in my first year of studies at university, showing this incredible finding. When you take people at very high risk of developing type 2 diabetes and you randomly allocate them to one of three groups: placebo, metformin, which is a standard drug used in the treatment and sometimes prevention of type 2 diabetes, and a lifestyle intervention, you can decrease the incidence rate. So the number of new cases of diabetes in this high-risk population by 58%. And that is considerably more than metformin can. So we have a direct connection here. So you look at this study and you say, this is probably as beautiful as it gets. I cannot think about many better studies. And you wonder, how long will it take to implement that into standard care? And of course, the critical people will say, well, who knows how long this lasts? Well, the answer is, it lasts 10 years, as we have learned from a follow-up study that followed up these cohorts. So although the critical mechanism of weight loss doesn't last forever, the intervention effects do last a long time, over 10 years, and so that is not a problem. So other critics will say, well, it might only work in the United States. Well, that too didn't happen to be true. So the Finns published a similar study within weeks of the Americans, and we now have studies in China, in Japan, in India, showing very similar findings. So it seems to be a global, sustainable effect. Why is it not implemented? In England, the Gordic knot was cut when people realized they're running out of finances for their healthcare system. And they're running out of finances for the healthcare system because we can no longer afford the costs associated with non-communicable disease, because essentially it is impossible to sustain a system without a certain level of prevention. So suddenly the dial was switched and prevention was on the agenda. And that was really run by costs more than by evidence, realizing that the costs of type 2 diabetes in particular overstretch the abilities of the system. So then a systematic review was commissioned of follow-up studies to those big trials that I've shown you, trying to implement these type of interventions in a more real-life intervention, and trying to ask the question, what is it that we need to deliver to get significant reduction? And they found that in the more real-life studies, the actual reduction in incidence was no longer the 58% that I told you for the very controlled, very professional trials, but it was 26%, which is still more than worth having, very attractive. And they tried to find out what are the key mechanisms, what are the key factors associated with the more effective intervention studies here. And based on this, they formulated a national strategy, a national specification of a service that could be commissioned to non-health service agents. So if you can deliver the intervention and if you can deliver the data that comes with it, you can apply. And then 4 national delivery companies were chosen. And based on this, 7 regions within England were used for an initial rollout. And in this initial rollout, we evaluated the fidelity of the intervention, we evaluated participation and reach, we evaluated data collection, and we further optimized the intervention to then become part of standard healthcare in England, which was then subsequently delivered in 3 additional waves across the entire country. And then, I want to say 17 years later, but it doesn't quite add up to 17 years, we find that indeed this intervention delivered at scale reduces type 2 diabetes, not at 58% as in the top trials, not at 26% as the more applied studies showed, but still at about 6 to 7% in the first years, which is very much cost-effective and worth having for the English health system. And we now have a national service that delivers this evidence more than 20 years later to the people in England. But we don't have this in Germany, and I don't know whether we have this in France. I doubt so. I don't know about this. And I realize that, again, here we have an opportunistic implementation of a really important piece of evidence, which took so many years to deliver, and we still can't deliver it to everybody. A much quicker example for translation into policy was our work on diabetes remission, where we showed that based on a theory of my colleague Roy Taylor, in principle, diabetes can be reversed, can be brought into remission. And we got together based on our work, mostly Vera and my work, on changing behavior for weight loss and sustaining weight loss over time. And we developed the DIRECT trial, which is the first trial that tried to see whether diabetes can be brought into remission in standard primary care in Scotland and England. And the intervention consisted of initial screening for eligibility, and then essentially of diet replacement. So people stopped feeding themselves, were fed with shakes and bars in a way that is very much nutritionally composed and very clearly described. It was followed by a stepped food reintroduction and a following weight loss maintenance period. And the goal was to achieve 15 kilograms of weight loss in individuals, which is of course very challenging. So we found that after a year, 24% of the intervention arm has reached that target of weight loss, and after 2 years, 12%. But more important, and that's the other part of the graphs here, after a year, almost half of the participants in the intervention arm were in remission, and after 2 years, still over a third. And that was then further broken down by weight loss, and it shows that the more weight people lose, the longer and the better the remission. And this was immediately implemented in a national service, and in a national service that delivered the intervention with some levels of variation, so it could be optimized. And about half of the participants completed the intervention, and of those, 32 are in remission. And so again, we have an example here how evidence from trials gets implemented into the real world and can actually show very cost-effective, very relevant changes, even at scale. But as you have seen, there are many questions to be answered on the way, and aside from the passion of everybody in this room, what it sometimes takes, and aside from the research funding we need, is a clear methodological and conceptual framework. We have seen this in standard health technology assessment with the introduction of Cochrane, for example, with NICE in England, with the Equator Network. We have methodologies that help us to streamline the process, and in that, my feeling is that the work of this Non-Pharmacological Intervention Society, in particular the work towards a registry, is a very important step because it helps to give people the confidence and the understanding of these sometimes very complex evidences to make sure that the path from evidence to implementation to an improvement of the health of the people is streamlined. And on that, I thank you very much for your attention, and I'm hoping we have some time for discussion.
Thank you very much, Falko. Thank you very much, Professor SNIEHOTTA. I believe that many people who are here in this room are working on day-to-day basis with patients, implementing non-pharmacological interventions, but you showed us what is the next step, what is the next level, and how it can be done. So definitely there is a space for questions from the audience who would like to ask something, please?
Thank you very much. I don't know whether you guys can see us over here in the audience. Simon Bacon, Montreal, Canada. Amazing presentation. I'm going to take a step back to DPP, just because the story is worse than we think it is, because DPP was 30 years in the making. So effectively it took us 50 years to go from the beginning of that to actually implementing into practice, which raises this really important question about how do we need to restructure healthcare systems to be able to fast-track that process. And obviously you've had a huge amount of success in the UK doing that, and I'm just wondering if there are some key things that you think are critical that other countries need to take on board to make that a reality.
Thank you very much, Simon. That is a great question. So because it was too easy to do this in England, I moved to Germany. It's a country that spends more money on health than any other country in the European Union and has got some under-average health expectancy. A country in which evidence is not a topic that we normally hear discussed. I noticed, even with my poor French, that most of your stakeholders mentioned evidence. There is no regular training in civil servants on the use of evidence. There is virtually no budget for evaluations. And I think that's where it starts. Yeah, when I went to England in the year 2004, there was a commercial in the 8 o'clock commercial break before the news that ended with the slogan, "Get randomized." And as a German boy, I sat there and say, "Get what?" I mean, you cannot say this to a German, but there's a culture where evidence and the value of evidence is communicated not only to policymakers and officials, but also to the population. And I think it is a really important part that if we want to deal with some of the challenges that our societies will deal with over the years, that are caused by climate change, that are caused by the fact that we are currently no longer in a state of peace, that are caused by the predictability of multiple crises, the use of evidence for public decisions is just absolutely vital. And that acknowledgement, also in the sort of sense of leadership, is the first important thing. The second most important thing, and that is infrastructure. Yeah? The moment you have a clear infrastructure, how options for interventions are evaluated, how interventions might get highlighted that haven't been currently in the discussions and considerations of policymakers, is a really important point. And then it's methodology. We are not always answering the questions that need to be answered. There is an obsession about randomized trials, and I do love to do them. And you have seen some of the work there on the slides, but of course all the questions about reach, about implementability, about maintenance are really important. So it is really about focusing the research on translation from the beginning, but also having a system in place that allows for translation. And there we can learn from each other, because most countries have some good infrastructure, but few countries have a really good set of infrastructures. And that's, I suppose, also why I acknowledge the internationality of the endeavor here, because this kind of exchange could be absolutely vital.
The great thing about wonderful presentations is they raise as many questions as they answer, provide answers. One of the things I was curious... Oh.
Wow.
One of the things I was curious about, having done a fair amount of sort of PPI research, where the various different knowledge users drive the process, thinking about translation of our interventions into public health, how much should it be the issues that are most predominant that public health is trying to tackle that we start with versus the evidence base that's starting to come through? I mean, a number of things are universal, but there are so many competing interests and so many competing possibilities. And I'm just wondering if you've got a sense of how much of a balance we need to have between what what public health is asking for versus what the evidence actually supports in terms of where we should move forward with.
Thank you. That was a great question that deserved the light effect that you got there. PPIE, also the involvement of patients and members of the public in setting research agendas, in doing research and implementing it, is as difficult as it is important. Yeah, we rarely manage to get the right people into the room for these activities. In particular, with my policy research unit, we are having actually a public members panel that helps us to address the public members' issues in the first place, so as an intermediate level. And we notice that there is almost no voice of people in the setting of the agendas, and that there is some voice of realizing innovations and solutions in the area that still isn't always heard. And this disconnect remains a really big problem. And generally speaking, it is important to move health into the public domain. We need to, it's not possible that we talk about politics without talking about health. Health addresses issues that everybody is interested in, and in the absence of a public debate, we don't manage always to get the voices of the people who are most effective heard. At the same time, I'm a big advocate of taking low-hanging fruits. So if you have an intervention of which you know it works and it's cost-effective, yeah, sometimes I just feel we need examples of success. If we can all sort of say, look, here was something, we told you it would work, you implemented it, and it did work, and it made people better, and it even possibly saved you money, then it's so much easier to discuss this. And I think that's a big difference between the countries that are good in doing this and those that aren't good in it, is often just one or two good examples. Yeah, and especially some of the, I take Germany as an example, because I might be the only German here, yeah? We're just not very good in changing, yeah? For a long time it wasn't needed, and now that it's needed, we are failing with any task that is related to change. And so I think that one or two examples that would simply show it can be done and it doesn't hurt is really important. But the problem really with politics, and I do work a lot with ministers, is not the majority of the people. So the majority of people in Germany favors the introduction of a sugar levy on sugar-sweetened beverages, as the evidence suggests all over the place. People are not concerned about the majority, they are concerned about the loud 5% who will make their life hell. And if we can make people's life hell for the need of wearing masks while we are looking into an aerosol transmittable disease, we can make people's life hell over some sugar in Sprite, although all the evidence internationally has shown that it does address the right people and that the producers of Sprite have not had any cut to their turnaround, which is often also important issue when you talk to ministers to understand the alternative intervention effects. Let me say one more thing, which is really quite important. Yeah, as I talk a lot to ministers, it is often not the health evidence that sways them. So they understand that the intervention has an effect on health, but they have all sorts of suspicions about what else it does, in particular links to economic productivity and perceived fairness. And my feeling is that if you really want to implement something, just start studying those effects as well from the beginning. Start building a sort of logic model of the intervention's effect on various outcomes, health and non-health, and be able to feed a decision model, because often it is the case that the fears and the suspicions that policymakers have about intervention effects, in particular on the response of the population and in regard to economic effects, aren't really founded. But because they are undefined and because we don't have answers, they allow for enough ambiguity to not consider changes. And I think that is an important point.
Yeah. Thank you very much, Falko, once again.
Thank you.